A 6 weeks old male infant brought to emergencies for poor feeding, lethargy, difficulty breathing for 2 days. Baby appears sweaty during feeding, has reduced wet diapers, and on examination, baby is pale, tachypnic, RR 70 per minute, heart rate 190, BP 60/40, weak peripheral pulses, hepatomegaly, and loud pancystic murmur over left lower sternal border. Okay. So, what is your immediate approach to assess this child?
So my immediate approach, I will follow the airway breathing and circulation. As the patient is tachypnic with tachycardic, so I think the patient is in respiratory distress. I will put on oxygen support. For this child, I'll put on high flow mask 15 liter per minute at the moment as the initial resuscitation measure. Then of course, before that, I'll put on the vital sign monitoring, and then we see the response. But while put on the 15 liter per minute of high flow nasal cannula, I also need to secure the breathing. So I'll check the SpO2, make sure the SpO2 is above at least 92%, maintain prevent hypoxia. And as I can see, the patient is also having a hypotension. I will quickly insert the granular, peripheral granular, and start the patient. The patient is actually in the decompensated shock. So I will give a fluid bolus of 10 mL per kg of normal saline to regain the circulation. But of course, I will monitor the child regularly. I will monitor constantly. I mean, all the time.
Okay, so what are the aspects of that clinical history and physical examination that support this one is cardiac in origin?
There is a loud pancystic murmur with failure symptoms, including poor feeding and also diaphoresis on feeding, and there's a reduced urine output. So I think it's a cardiac origin. Most probably is in most probably from the history and physical examination. My differential will be a VST in failure.
Okay. Other than congenital heart disease, what are the differential that is possible?
There's a loud pancystic murmur at the left lower sternal edge. So my first still VST. Okay. Could be AVST.
Okay.
And
Other congenital?
Other congenital, if it's a cyanotic heart disease, could be tetralogy or Feller.
Okay. Anything that can present the same thing but not necessarily have to be defect, but still congenital heart problem? Congenital heart disease, but it's not really a VSD or AVSD, but still can present this very sudden collapse.
Yes. Maybe prolonged QT syndrome.
No.
Sorry, was that not congenital?
Yeah, this child about 6 weeks of age, datang dengan sudden collapse like this. What are the possible thing? Especially the peripheral pulses are weak.
Okay. Peripheral pulses are weak is a coarctation of the aorta.
Yes, coarctation also can. Don't forget your hypoplastic also lah, all those problem. Okay, that one is congenital. What are the other cardiac problem but can present the same thing, same way?
Still cardiac origin,
yes.
Inflammation, Myocarditis.
Okay. Specifically apa? No, pericarditis lah, apa lagi?
Pericardial effusion.
No. Tachycardic like that. What must you think of patient tachycardic like that? Got murmur some more. So the murmur not necessarily because of congenital heart defect. What else?
Acquired one would be
Yes, acquired one.
infective endocarditis.
Not so early lah.
Rheumatic.
Not so early also. 6 weeks old lah.
Yeah, 6 weeks old.
Especially at the prodromal symptoms. What else you have to think about? Prodromal symptom like upper tract infection. This viral illness can cause problem to the heart. What you call the problem? Inflammation of the heart you call what?
Myocarditis.
Yes, myocarditis lah.
Okay.
What do you think the cause? If myocarditis, what are basically the first thing you have to think about? The cause of myocarditis. Remember Iskandar?
Yeah, it's kind of. Oh, okay. Infection, viral, cytomegalovirus, CMV.
Yes, so viruses lah. So what are the common viruses kaya myocarditis?
CMV,
Samo?
EDV,
Samo?
EDV, other viruses.
What else you send? That viral panel for myocarditis, EBV, CMV, apa lagi?
Of course, influenza and other. Influenza, rhinovirus, enterovirus.
Don't forget your COVID-19. Don't forget
COVID.
your parvovirus. All those things are probably the first line viruses that you always send lah. Okay. So if myocarditis another problem, cardiac related, but it's not really myocarditis, not really congenital heart defect.
Cardiac related. With murmur.
Yeah, with murmur.
With murmur.
Because poor heart function.
Poor function.
Heart function poor, got murmur lah because of mitral regurg, tricuspid regurg. What else can cause dilated chambers?
Dilated chambers.
Remember genetic metabolic problem.
Syndromic child.
Yes, but related to the heart problem lah.
Syndrome that's related to heart.
What is metabolic heart problem?
Metabolic heart problem. Sorry, never heard of that metabolic heart problem.
Of course got. If you know, of course if patient datang dilated myopathy like that, so you have to think about. So and that basically another point is cardiomyopathy lah. Cardiomyopathy and myocarditis is two different things lah. Cardiomyopathy.
No, cardiomyopathy because of cardio.
No, cardiomyopathy is just basically another clinical problem for the heart. Okay, myocarditis is specific problem lah. Okay, so if you have cardiomyopathy, not necessarily you have myocarditis. Okay, but they both present the same way. Heart looks very dilated, poor heart function lah. So if cardiomyopathy, what are the common cardiomyopathy causes? I know it's a bit hard question, but
common cardio.
but this one all just go back to Iskandar. What else do we send?
Send
under investigation. I'm
investigation.
sure you probably managed him one day to this before
Yeah,
the balik.
yeah.
He was in the ward for quite some time. What else do we send other than viral panel?
In the viral panel.
Other than viral panel?
Oh, other than viral panel, we send chop eye.
Okay.
Yeah, I think
No, to look for the cause.
to look for the cause.
The clue I given just now already, genetic metabolic. So what do we send?
Genetic.
Usually kalau you suspect metabolic problem, what you send?
Oh, we send IEM, the
IEM.
blood spot.
Yes.
We did send blood spot, plasma amino acid, and also urine organic acid.
Okay, alright. For sure, you have to send those. For sure, you have to
I
send.
know specifically what
Okay,
to
if you refer genetic, they will probably send the cardiomyopathy panel lah. Okay, specific gene mutation problem for cardiomyopathy. Specifically that you can send without the panel, you can send for what disease that present with cardiomyopathy. Baby is hypotonic.
What disease?
Start with P. They are hypotonic. They very hypotonic, very lembik.
Prader-Willi syndrome.
No, Prader-Willi don't have heart problem per se. Ada lah, but they don't present with cardiomyopathy. P. O.
Poland syndrome.
M. P-O-M apa? Form apa? Wah, Pompe. Pompe disease. Don't forget about Pompe. So Pompe disease, usually the baby is hypotonic. They very lembik. Okay, so hypotonic baby other than your Down syndrome, Prader-Willi, must think about Pompe lah. Especially if they come with cardiomyopathy lah, mean dilated heart. Okay, so you can send the Pompe punya bloods lah. Dia ada specific blood lah you can send to IMR. Okay, alright. Okay, so the presentation typical lah, Swiss all datang dengan neonatal collapse like this, right? Datang dengan poor feeding, lethargy, difficulty of breathing. So other than the heart problem, dia ada non-cardiac punya problem apa lagi? Neonatal collapse.
Neonatal collapse. Respiratory causes, such as pneumonia, the most common one.
Okay.
Then CNS wise, could be meningitis and colitis.
Okay, alright. Or bleed lah. Okay, don't forget your sepsis lah, basically. Alright, so investigation wise, what you want to say?
Investigation at the acute.
What you want to order? Yeah,
acutely do a blood gas to see the component, whether it's a respiratory or metabolic component.
Okay.
And of course, IPC will be helpful as the patient is pale. I like to look at the hemoglobin, and then white cell can give us some clue whether it's an infection or not, and then whether it's viral or bacterial causes. And also RP, renal profile, see whether there's any electrolyte dysfunction, electrolyte imbalance that causes cardiac problem, and also want to see if there's any signs of dehydration. And of course, with this kind of case, we're planning to start anti-failure, and then want to see the renal function as well.
Okay.
Then the other one is a liver function test.
Okay.
Alright.
Those are very basic lah. So any imaging you want to do?
Imaging, of course, chest X-ray will be beneficial.
Alright.
And refer cardio for an echo.
Okay.
To see the cardiac function and any abnormalities.
Okay. So let's say on X-ray cardiomegaly, plethoric lung field, ECG just sinus tachycardia, echo just very dilated chambers, poor heart function. So the impression, myocarditis. Okay, so how you want to stabilize the airway? Patient very tachypnic.
Very tachypnic. Still tachypnic despite the high flow. So we will of course assess with the patient. We are expecting there's impending respiratory collapse.
Okay.
We'll intubate the child. And intubate the child. Then send to ICU for airway stabilization.
Okay. Alright. So you have you done ICUs?
Yeah.
The ICU only lah.
PICU.
PICU also. Okay. PICU you've done what? SMO state. MO.
MO, yeah.
Where? When?
HTA.
HTA lah. Okay. So if you have a cardiac problem, ICU management.
Okay.
At least the principle of it lah. Okay. So kalau you have this cardiac problem, your ventilation strategy, what must you avoid?
We must avoid. What must we avoid?
During that ventilation setting to PEP, PIP.
We must avoid too high FiO2.
Too high FiO2, okay. But that's not what I want.
We just maintain a normal PIP and PEP.
Okay.
As this is not respiratory.
So specifically the one avoid what?
Avoid PIP.
No, not really. High PEP. Don't give too high of PEP lah. Because what happened? Kalau you give very high PAP,
There will be more compression to the heart.
is it compression to the heart or is it compression to the blood vessel?
Sorry?
Is it compression to the heart or is it compression to your IVCs?
Compression to IVC. Then there
So
will be
less
venous return.
Yeah, so less venous return, less cardiac output.
output.
The heart already poor in the first place. Okay, so you don't give very very high PAP lah. 6-7 probably enough lah. You give too much then reduce venous return, reduce heart function. Heart already poor to begin with lah. Okay, so that's one. Okay, in terms of fluids.
Please try not to give too much fluid as the patient is already over. There's a poor cardiac function. We are afraid of overloading the child. So half to total maintenance will be good.
Okay, so just restrict accordingly lah. Don't restrict too much. Don't give too much as well. Alright, in terms of inotropes, especially patient at hypotension ni.
Hypotension, no adrenaline will be the first one.
No adrenaline.
Dopamine is the wet lung. Right?
Okay.
Yeah, this is a wet. It's a ventilation failure. Dopamine will be a better choice than.
Okay. Can, but usually, to support the BP, most of the time we start with what?
Inotropes.
Cardiac problem.
Cardiac problem.
Dopamine can.
Dopamine.
Dopamine we try to avoid.
Yeah,
you don't want the tachycardia. Right?
Adrenaline
low. Adrenaline low dose, not very high dose. They are very good for the cardiac problem lah, especially the low cardiac output punya poor function.
So start with adrenaline.
Most of the time I just start with adrenaline first, get the BP up. Don't give too high of adrenaline. Then after that you can support with low dose the rest lah, the dopamine apa tu. But the aim is either to start in the end dobutamine or another drug. So what?
Another drug is inotropes.
Dobutamine or
dopamine. No adrenaline.
Adrenaline no. That one kalau BP still low, you can give lah low. Like sampai in the end, the aim is to start dobutamine. And another one start with M apa?
Start with
M.
M.
What vasoactive agent that start with M?
Ada. Tak guna lagi.
MIL. Okay.
Mirinon.
Yes, start Mirinon lah. So the problem when you start Mirinon, even dobutamine, if BP is low already, can cause even hypotension lah. So sometimes you have to support the BP first and baru start Mirinon lah. Of course, it's still vasoactive agent later on. If heart rate everything okay, volume status is okay, this even Mirinon and dobutamine also can cause high BP as well lah. But it's more on Mirinon lah rather than dobutamine. Dobutamine most of the time I start can cause high BP high as well lah. Okay. Alright. So but most of the time the choice is always Mirinon lah, because Mirinon really relax the heart and reduce the afterload as well. Okay. Alright. So you know the diagnosis is myocarditis. How you want to treat specific for myocarditis? What treatment can we give?
What treatment? Anti-inflammatory.
What is it?
Which one will be IV methylprednisolone?
No, not the first one. What is much safer, much prednisolone is not really the first line.
IVIG.
IVIG lor.
Yeah. We'll start IVIG first.
Give IVIG lah. Okay. Alright, so other than IVIG, the heart failure, what medication you can give?
Can give two types. The commonest one are furosemide and also spironolactone.
Alright.
And then we see whether we need a captopril on top of them.
But you already have Mirinon. They're working basically the same thing lah. So if you stop Mirinon, you have to overlap with captopril lah later on. Okay.